Welcome to the deep dive. Today, we're taking a fascinating journey into a really crucial area of health and nursing, the eye and the ear.
That's right.
We'll be exploring their anatomy, how they work, how we assess them, the tests, and, a whole range of disorders that can affect them.
And our guide for this is the chapter from Saunders Comprehensive Review for the NCLEX-PN Examination, 7th edition. A really solid resource.
Definitely. So if you're looking for a clear, efficient way to get your head around these, well, complex sensory systems,
How we see and hear and the vital nursing side of things.
then yeah, you're absolutely in the right place. This deep dive should give you that solid foundation.
Our goal is pretty straightforward, really. We want to pull out the most critical info from this chapter.
Make the medical terms make sense.
Exactly. And just give you a structured overview so you feel informed, not, totally swamped.
And while we go through this, it's worth keeping in mind those core concepts the chapter highlights: safety and sensory perception.
Absolutely central to nursing practice. Understanding how these senses work, what goes wrong, it's paramount for patient safety, patient well-being.
Yeah, and the chapter even kicks off with a scenario, right? A client with a sudden eye injury.
Very relevant.
Keep that in mind, because we'll circle back to it later, along with the review questions, see how this knowledge actually applies.
Sounds good.
Okay, let's dive in. Starting with the eye, it's amazing. Design, anatomy, how it all works.
Right, so the eye, the book tells us it's basically a globe about an inch across.
Wow, only an inch.
Roughly, yeah. And it sits there in the front part of the orbit.
Mm-hmm.
And the orbit itself, that bony socket, that's like its built-in protection.
Natural shield makes sense.
Keeps it safe. Now, the eye itself has 3 main layers.
Okay.
The outermost one is the external layer, or the fibrous coat. Think of it as the tough, supportive shell.
Right, holding everything together.
Yeah. And that includes the sclera,
Mm-hmm.
the tough white tissue.
The white of the eye.
Exactly.
Okay.
And right at the very front, still part of this outer layer, you've got the cornea.
Ah, the clear bit.
Right. It's dense, but it has to be transparent.
Uh-huh.
Super clear. Because that's where light first enters the eye and starts bending or refracting.
To focus it towards the back.
Precisely.
Yeah.
Okay, so moving inwards, we hit the middle layer,
Mhm.
also called the uveal tract.
Radial tract.
This one has 3 key parts: the choroid, the ciliary body, and the iris. Let's start with the choroid.
Okay.
The choroid is interesting. It's this dark brown membrane lining the inside of the sclera.
Why dark brown?
Well, that darkness is crucial. It absorbed any stray light bouncing around inside the eye, stops reflections that would just blur everything.
Like the inside of a camera.
Exactly like that, a dark room. Plus, it's packed with blood vessels that feed the retina. One thing to note, though, is it can detach sometimes.
Okay, good to know. What's next in that middle layer?
The ciliary body. This connects the choroid to the iris, and it does a couple of really important things. It produces the aqueous humor that's the fluid that helps keep the eye's shape.
Right.
And maybe even more importantly, the muscles in the ciliary body. They control the shape of the lens.
Ah, for focusing. Near and far.
You got it. And then the third part of this middle layer is the iris.
The colored part of the eye?
Yeah, that's the one. Sits right in front of the lens.
Yeah.
And that hole in the middle, that's the pupil.
And the iris controls the pupil size.
Exactly. Its muscles adjust the pupil opening to control how much light gets into the retina. Smaller in bright light, bigger in dim light.
Just like a camera aperture. Makes sense.
Totally. Okay, now for the innermost layer, the internal layer, this is where the real visual magic happens, thanks to the retina.
The retina. Delicate, right.
Very delicate. It's thin, packed with nerve fibers that actually form the optic nerve. This is the eye's visual receptive layer.
So it senses the light?
It senses the light and converts those light waves into electrical signals, signals the brain can understand as images. It's sandwiched between the choroid and the vitreous humor, and it's full of blood vessels and those crucial photoreceptors, rods and cones.
Okay, you mentioned vitreous humor. Let's talk about the vitreous body. That fills the main part of the eye.
Yeah, the big space between the lens and the retina, the vitreous chamber. It's filled with this gel-like substance.
It's vitreous humor.
Right. Its main jobs are to transmit light clearly back to the retina and to help the back part of the eye keep its round shape.
Like internal scaffolding.
Kinda, yeah. Gives it structure, supports the retina, keeps everything in place.
Okay. And back to those photoreceptors, you mentioned rods and cones.
Right. 2 types of light-detecting cells in the retina. Rods are super sensitive to light. They handle our peripheral vision and let us see in dim light. Think night vision.
Got it. Rods for low light and cones.
Cones need brighter light. They're responsible for our sharp central vision and, importantly, our color vision.
Cones for color. Easy enough.
Yep. Now, there are a couple of specific spots on the retina we need to know about. First, the optic disc. This is a slightly depressed area, usually creamy pink or whitish. It's where the optic nerve fibers all gather together to leave the eye.
The exit point.
The entry and exit point for the optic nerve. And crucially, it's our blind spot.
Blind spot. Why?
Because that specific area, it only has nerve fibers, no rods, no cones, so it literally can't detect light falling on it.
Huh. Okay. And the other spot?
That's the macula lutea, or just macula. It's a small oval area, yellowish pink, off to the side of the optic disc.
Okay.
And right smack in the middle of the macula is a tiny dip called the fovea centralis.
Fovea. That sounds important.
It is. The fovea is where our vision is sharpest, most detailed, highest acuity.
So the macula and especially the fovea are key for things like reading.
Absolutely. Reading, recognizing faces, seeing colors clearly, even detecting motion. All that detailed central vision relies on the macula.
All right, let's switch gears slightly and talk about the fluids in the eye. Aqueous humor.
Right. This is a clear, watery fluid, not the gel stuff at the back. This fills the front parts of the eye.
The front parts.
Yeah, the anterior chamber that's between the cornea and the iris, and the posterior chamber, which is between the iris and the lens.
And what does it do?
It nourishes those front structures, helps maintain the eye's shape. Think of it like a bath for the cornea and lens.
And it's constantly being made.
Constantly produced by little structures called the ciliary processes. But if it's always being made, it also needs to drain out.
Otherwise, pressure would build up.
Exactly. And that drainage happens through the canal of Schlemm.
Canal of Schlemm, okay.
It's like this tiny circular channel running around the edge of the iris. It collects the aqueous humor and drains it back into the bloodstream.
And that constant production and drainage, that's what keeps the eye pressure stable.
Precisely. Maintains a constant intraocular pressure, or IOP. Super important.
We'll definitely come back to IOP later with glaucoma.
Oh, absolutely. Okay, Dev, let's shift focus, literally, to the lens.
Behind the iris?
Yeah, behind the iris, in front of that vitreous gel. It's transparent, and it's convex curved outwards.
And its job is focusing light.
Its critical job is focusing the light rays precisely onto the retina. And the amazing thing is, it can change its shape.
Change shape? How?
It gets flatter to focus on distant objects.
Yeah.
And more rounded or curved to focus on things up close. That adjustment is called accommodation.
Incredible. Okay, what about the conjunctiva?
That's a thin, transparent mucous membrane. It lines the inside of your eyelids and then folds back to cover the white part of the eye, the sclera.
So it protects the surface?
That protects and lubricates.
And tears, where do they come from?
Tears are produced by the lacrimal gland, which sits up in the upper outer corner of each eye socket.
Okay.
Then they wash across the eye and drain out through tiny holes called puncta on the inner corners of the eyelids.
And go where? Into the nose?
Yep, down through the lacrimal ducts and sac, eventually emptying into the nasal cavity. That's why your nose runs when you cry sometimes.
Ah, makes sense. Now, eye movements, muscles.
Absolutely. 6 extraocular muscles attached to each eye, working in beautifully coordinated pairs. You've got 4 rectus muscles, superior, inferior, medial, lateral. They pull the eye up, down, inwards towards the nose, and outwards towards the temple.
Okay, 4 directions. What about the other 2?
Those are the oblique muscles, superior and inferior. They handle more rotational movements, helping tilt the eye. It's a really precise system.
And all controlled by nerves.
Definitely. Several cranial nerves are involved. Cranial nerve 2 is the optic nerve itself, carries the visual signal.
Right.
Then you have cranial nerves, third, oculomotor, fear, trochlear, and sixth abducens. These guys control those 6 muscles, making the eyes move together.
Complex coordination.
Very. And finally, blood supply. Like any organ, the eye needs blood.
Makes sense.
The main supply comes from the ophthalmic artery, and drainage is through the ophthalmic veins.
Okay, I think that covers the eye's A&P pretty thoroughly. The book mentions vision assessment is in another chapter, so we'll skip the details on that.
Right. But we can talk about how we diagnose problems when things go wrong with the eye, the diagnostic tests.
Perfect. Let's dive into those. First up is fluorescein angiography. Okay, that sounds technical. Break it down for us.
Okay, so fluorescein, that's a type of fluorescent dye, and angiography means imaging blood vessels.
So imaging eye blood vessels with dye?
Exactly. It's a pretty sophisticated test. They inject that fluorescein dye into a vein in your arm.
Okay.
As it circulates, it reaches the blood vessels in the retina and the choroid at the back of the eye. A special camera then takes rapid-fire photos.
What does that show?
It lets doctors see the blood flow very clearly. It's fantastic for diagnosing things like diabetic retinopathy, finding bleeds, checking for macular degeneration, or even spotting tumors.
Sounds useful. What's involved beforehand? Any prep?
Yeah, there are a few key things. First off, always check for allergies to the dye. That's critical.
Right.
Need informed consent, of course. Then, about an hour before, they'll use mydriatic eye drops to dilate the pupils really wide.
To get a better view.
Exactly. Then the dye injection in the arm. And you need to tell the client what to expect afterwards.
Like side effects.
Yeah, temporary ones. Their skin might look a bit yellow for a few hours.
Yeah. Okay.
And their urine might turn bright green or orange for maybe a day or two. It's just the dye being filtered out.
Good to warn them. Anything else?
They might feel a bit nauseous, maybe sneeze, get a funny taste or tingling, sometimes pain at the injection site. If they get hives, antihistamines can help.
And after the test?
Rest is good. Drink plenty of fluids, helps flush the dye out faster. Reassure them the skin color goes back to normal quickly, the urine color too.
And the dilated pupils.
Right, they'll be sensitive to light photophobia.
Yeah.
So wear sunglasses, avoid bright sun until the pupils are back to normal size.
Okay, got it. Next test. Computed tomography, CT scan. We're probably more familiar with this one. How's it used for eyes?
CT uses X-rays and computers to create cross-sectional images. For the eye, it's great for looking at the eyeball itself, the bony orbit around it, and those extraocular muscles.
Can see bone well, right?
Exactly. Sometimes they use IV contrast dye to see certain tissues better, but usually not if they suspect trauma, like a foreign object.
Any special prep for an ICT?
Not usually.
Yeah.
Just need to lie still on the table that goes into the scanner. If contrast is planned, you definitely need to ask about iodine or shellfish allergies.
Okay. What about the slit lamp examination? Sounds specific.
It is. A slit lamp is basically a powerful microscope combined with a very bright adjustable beam of light like a slit.
Okay.
You sit with your chin and forehead on rests to keep still. The examiner uses that narrow light beam to light up different parts of the front of the eye, cornea, iris, lens.
And looks through the microscope?
Yep, under high magnification. Lets them see tiny details and abnormalities on the front structures.
What should the patient expect? Just a bright light?
Pretty much, a very bright light directed at the eye. They'll be asked to look straight ahead or follow directions to look at specific points.
All right. Corneal staining. How does that work?
This uses a topical dye, often fluorescein again, but just as drops. You put it in the eye, usually in the lower lid conjunctival sac.
And what does the dye do?
It highlights any scratches, abrasions, or defects on the surface of the cornea, the clear front window. Things you might not see otherwise.
How do you see the staining?
After the dye is in and you blink a bit to spread it, the examiner looks at the eye, usually with the slit lamp again, but using a blue filter light.
Yeah.
And any area where the surface layer, the epithelium, isn't intact will glow bright green, shows exactly where the damage is.
Clever. Need to take contacts out first.
Oh, definitely. Contacts out before the dye goes in.
Okay. Tonometry. We mentioned this relates to eye pressure, IOP.
Yes, tonometry measures the intraocular pressure, crucial for detecting and managing glaucoma.
Right. Two types mentioned, non-contact and contact.
Correct. Non-contact tonometry is often called the AirPEF test.
Ah, I think I've had that one.
Probably. No anesthetic drops needed. A machine blows a quick puff of air at your cornea.
It does make you jump.
Yeah, it can be startling. It measures how much the cornea indents from the air puff to estimate the pressure. Quick, but maybe less precise than the other method.
Which is contact tonometry.
Right. For this one, you do need anesthetic eye drops to numb the surface.
Okay.
Then a small flattened cone on the tonometer gently touches the cornea. The instrument measures the force needed to flatten a tiny specific area.
And that force relates to the pressure inside.
Exactly. It gives a very accurate IOP reading.
Yeah.
Since the eye is numb, it doesn't hurt, but afterwards you have to tell the patient, don't rub your eye.
Why not?
Because it's numb. You could easily scratch the cornea without feeling it. Wait maybe 15-20 minutes for the anesthetic to wear off.
Good point. And normal IOP range again?
Generally 10 to 21 millimeters of mercury millimeter Hg. Can vary a bit, often higher in the morning. Important to document the reading and the time.
Okay. Ultrasound for the eye. Similar to other body parts.
Pretty much the same idea. Uses high-frequency sound waves. A probe is placed gently on the eye, usually with some gel.
And it creates images?
Creates images of the internal structures. Really useful if the view is blocked, like by a dense cataract.
Right.
You can see the retina, the vitreous, check for detachments, tumors, foreign bodies.
Got it. And finally, MRI, magnetic resonance imaging.
Right. Uses magnets and radio waves for detailed images. Great for soft tissues, optic nerve, orbit, brain connections.
Good for tumors or inflammation.
Excellent for those. But the big caution with MRI, always, is metal. Absolutely contraindicated if there's any chance of a metallic foreign body in the eye. The magnet could move it.
Huge risk. Okay,
Yeah.
that covers the key diagnostics. Now let's get into the disorders themselves. The chapter starts with general risk factors.
Yeah, kind of sets the stage. Box 53-1 lists things like aging. That's a big one for many eye conditions.
Makes sense.
Congenital issues, so problems present at birth. Diabetes, huge risk factor for eye problems.
Like diabetic retinopathy.
Exactly. Heredity plays a role too. Family history. Certain medications can affect the eyes, and of course, trauma or injury.
Okay, let's tackle specific disorders. Refractive errors first. That's things like needing glasses, right?
Basically, yeah. It's when the eye doesn't bend or refract light correctly, so the image doesn't focus sharply on the retina. It leads to blurry vision.
And there are different types. Myopia.
Myopia is nearsightedness. The eye might be a bit too long, or the cornea too curved. Light focuses in front of the retina.
So you see close things okay, but far away is blurry.
That's it. The opposite is hyperopia, or farsightedness.
Eye too short or cornea too flat.
Right. Light focuses behind the retina. So distant vision might be okay, but close-up is blurry.
And presbyopia, that's age-related.
Yeah, usually starts hitting in your 40s. The lens inside the eye just gets less flexible with age.
Harder to focus up close.
Exactly. Same result. Trouble focusing on near objects. Focus point falls behind the retina.
Okay, one more. Astigmatism.
Astigmatism is usually due to an irregularly shaped cornea. Instead of being round like a basketball, it's shaped more like a football.
Uneven curve.
Uneven curve. So light focuses on multiple points, not just one. Causes blurry or distorted vision at pretty much all distances.
So how do they figure out which one you have?
Through an eye exam, specifically the refraction test. That's where you look at the eye chart through different lenses.
Which is better, one or two?
Exactly that. Helps pinpoint the error and find the right prescription.
And correction options. Non-surgical is mainly.
Eyeglasses and contact lenses. They bend the light correctly before it enters the eye so it focuses right on the retina.
Pretty standard. What about surgical options?
Several choices there. Older ones like radial keratotomy, RK for myopia, involves making cuts in the cornea.
Okay.
More common now are laser procedures. Photorefractive keratectomy, PRK, reshapes the corneal surface with a laser, good for myopia and astigmatism.
And LASIK, that's probably the most well-known.
Very common. LASIK creates a thin flap in the cornea. Laser reshapes the tissue underneath. Then the flap is put back. Works for hyperopia, myopia, and astigmatism.
Any others?
There are also corneal ring implants, tiny rings inserted into the cornea to reshape it, sometimes used for myopia.
Okay, lots of options. Let's talk about a more severe level of impairment. Legal blindness. What's the actual definition?
It's quite specific. Legally blind means either your best corrected vision in your better eye is 2200 or worse.
2200. Meaning you have to be 20 feet away to see what someone with normal vision sees at 200 feet.
Basically, yes.
Yeah.
Or the other criterion is your visual field is really narrow, 20 degrees or less in the widest part of your vision in the better eye.
So it's not necessarily total darkness.
No, not at all. It's a specific level of severe impairment that impacts daily function significantly.
What are some key nursing points when caring for someone who is legally blind?
Communication is huge. Always speak in a normal tone. Announce yourself when you enter or approach.
Startle them.
Right. Orient them really well to their surroundings. Describe the room layout. Use clock face terms for where things are like food on a tray. Your water is at 1 o'clock.
Okay.
Encourage independence as much as is safe. Provide access to things like talking clocks or radios, braille materials if they use them.
What about helping them walk?
Offer your elbow. Let them grasp it. You walk slightly ahead so they can follow your movement.
And the white cane?
If they use one, reinforce proper technique. Hold it in the dominant hand, sweep it side to side, keeping the tip just off the floor to detect obstacles, usually white with a red tip for blindness.
Good tips. Okay, moving on to cataracts. Most people have heard of these. What's actually happening?
A cataract is simply a clouding or opacity of the eye's lens, which should normally be crystal clear.
So it blocks light?
Blots or scatters the light trying to pass through to the retina. Result: blurred, distorted vision. And yeah, if it gets bad enough, it can cause blindness.
What causes them? Is it just aging?
Aging is the most common cause that's senile cataracts.
Okay.
But they can also be congenital, meaning from birth.
Okay.
Trauma can cause them a blow to the eye. Other eye diseases or systemic conditions like diabetes can lead to secondary cataracts.
Anything else?
Yeah, maternal rubella during pregnancy, being very nearsighted, lots of UV sunlight exposure over time, and long-term use of steroid medications are also risk factors.
And surgery is the main fix.
Surgery to remove the cloudy lens is really the only effective treatment, usually done when the vision loss starts interfering significantly with daily life.
What are the early signs someone might notice?
Early on, maybe just blurred vision, like looking through a dirty window. Colors might seem faded or less bright.
Okay. And later?
Later, maybe double vision in one eye, worsening night vision, needing stronger glasses more often. Eventually, the red reflex, that red glow you see in photos, might be absent, and the pupil can even look white.
Is it painful?
Importantly, age-related cataracts usually develop slowly and without pain or redness.
Okay. And the surgery involves taking the lens out.
Yes, there are a couple of main ways. Extracapsular extraction takes out the cloudy lens, but leaves the back part of the lens capsule in place.
Okay.
A common type of that is phacoemulsification, uses ultrasound waves to break up the lens, then it's suctioned out.
What's the other way?
Intracapsular extraction removes the entire lens and capsule. Less common now.
And they usually put a new lens in.
Almost always. An artificial intraocular lens, or IOL, is implanted right during the surgery to restore focusing power. Sometimes they might do a small procedure on the iris too, an iridectomy, to prevent glaucoma later.
What's key for nursing care before surgery?
Education is huge. Explain what to expect. Stress hand washing. And teach them how to avoid increasing pressure inside the eye afterwards.
Like what kind of activities?
No bending over at the waist, no heavy lifting, avoid straining with bowel movements, no forceful coughing or sneezing, definitely no rubbing the eye.
Got it. And they'll have eye drops.
Oh yes. Multiple types, several times a day, usually for a few weeks after surgery. They need clear instructions. Also, administer any pre-op drops like a mydriatics to dilate the pupil.
And after surgery?
Elevate the head of the bed 30 to 45 degrees. Position them on their back or the non-operative side. They'll likely have an eye patch or shield.
Important for safety.
Very. Orient them. Put things on their non-operative side. Use side rails. Help them get up and walk.
And discharge teaching. More of the same about avoiding pressure.
Absolutely reinforce. Avoiding increased IOP lifting, straining, bending. How to use their drops correctly. How to manage mild pain, usually with acetaminophen.
When should they call the doctor?
Definitely call if they have severe pain, a sudden decrease in vision, increased redness, or any discharge. Also, how to wear the eye shield, especially at night. No rubbing.
Okay, very clear. Let's move to glaucoma. We know it involves high eye pressure, right?
That's the hallmark. Glaucoma is a group of diseases where increased intraocular pressure, the IOP, damages the optic nerve.
And that causes vision loss.
Yes, gradual, irreversible vision loss, typically starting in the periphery, the side vision. Remember, normal IOP is around 10-21 millimeter Hg.
Why does the pressure go up?
Either the aqueous humor isn't draining properly through that canal of phlegm we talked about, or maybe the eye is producing too much fluid. Either way, pressure builds.
Are there different kinds of glaucoma?
Yes, the chapter focuses on two main types. Primary open-angle glaucoma, or POAG, means the drainage angle between the iris and cornea is open, but the drainage channels themselves, the trabecular meshwork, are clogged. It's the most common type, very gradual.
Okay. And the other type?
Primary angle closure glaucoma, or PACG. Here, the angle itself narrows or closes off, physically blocking the fluid from reaching the drainage channels.
What causes that blockage?
It can be the lens shape, or sometimes pupil dilation from dim light or certain meds pushes the iris forward, closing the angle. This can happen suddenly, which is an emergency.
What are the early signs? Is POAG really silent?
Often, yes. Early POAG usually has no symptoms. Vision loss is slow, painless, starting from the outside in. People might not notice until it's quite advanced, leading to tunnel vision.
Scary. What about angle closure?
PACG, especially the acute form, is dramatic. Sudden severe eye pain, blurred vision, seeing halos around lights, headache, nausea, vomiting. The eye often looks red.
That sounds like an emergency.
It absolutely is. Acute angle closure, glaucoma, needs immediate treatment to lower the pressure and save vision. Requires emergency meds, maybe laser treatment or surgery, like a peripheral iridectomy.
How is glaucoma generally managed, especially the open angle type?
The main goal is lowering IOP to protect the optic nerve, usually done with eye drops.
Different kinds of drops.
Lots of different classes. Prostaglandin analogs, beta blockers, alpha agonists, carbonic anhydrase inhibitors. They either help fluid drain better or reduce how much fluid is made.
And patients need to use these forever.
Usually, yes. Lifelong commitment is key. Compliance is crucial. They should also wear a medical alert bracelet.
Anything they should avoid.
Avoid over-the-counter meds with anticholinergic effects, as they can dilate pupils. Always check with their doctor before starting any new medication, even OTC eye drops.
And report any changes.
Report any eye pain, halos, worsening vision immediately. Regular eye exams are essential. If drops aren't enough, laser treatment or surgery like a trabeculectomy might be needed to create a new drainage path.
Okay. Retinal detachment. That sounds really serious. What's happening there?
It is serious. The retina, that light-sensing layer at the back, pulls away from the underlying tissue, the retinal pigment epithelium.
What causes it to pull away?
Often a tear or hole develops in the retina. Then the vitreous fluid can seep underneath and lift it off, or scar tissue might pull on it, or fluid can build up for other reasons.
And if it detaches?
It loses its blood supply and stops working. Can start small, but spread to the whole retina, leading to blindness if not treated fast.
What are the warning signs? Is it painful?
Usually painless. That's important. People often see sudden flashes of light, like lightning streaks off to the side,
Okay.
or a sudden shower of floaters, little specks or cobwebs drifting in their vision. A lot of new floaters can mean bleeding from a tear.
Any other visual signs?
Yes, a shadow or a curtain coming across the field of vision is a classic sign.
Hmm.
Starts in the periphery usually, but can move centrally, or just sudden blurred or wavy vision.
If someone has those symptoms, what should they do?
Get to an ophthalmologist or ER immediately. It's an emergency. While waiting, rest. Avoid sudden head movements. Both eyes might need patching to limit movement. Head positioning might be specific, depending on where the tear is thought to be.
And treatment is usually surgery.
Almost always. The goal is to get the retina back in place and seal the tear that caused it.
How do they do that?
Several ways. Pneumatic retinopexy injects a gas bubble inside the eye to push the retina back, combined with laser or freezing, cryopexy, to seal the tear.
Okay.
Scleral buckling involves putting a silicone band around the outside of the eye to indent it, relieving traction on the retina.
Sounds complex.
It is. Another option is vitrectomy, removing the vitreous gel and replacing it with gas or silicone oil to hold the retina flat while it heals.
What's recovery like after surgery?
Needs careful management. Eye patch, usually.
Hmm.
Monitor for bleeding, infection, increased pain. Nausea vomiting prevention is important. Straining raises IOP.
Bed rest. Specific positions.
Often bed rest initially, and positioning is critical. Depending on where the detachment was and if a gas bubble was used, they might have to keep their head in a very specific position for days, even face down.
Wow, that sounds tough.
It can be. Plus, eye drops, avoiding IOP increases, lifting, bending, straining, restricted reading for weeks. Need that shield at night. Follow-up is crucial.
Got it. Let's talk about macular degeneration. Affects central vision in older adults, right?
Primarily, yes.
Yeah.
It's deterioration of the macula, that central part of the retina we need for sharp, detailed vision.
Two types, dry and wet.
Correct. Dry AMD, age-related macular degeneration, is more common. It involves thinning of the macula, formation of yellow deposits called drusen. Progresses slowly.
And wet AMD.
Less common, but more severe. Abnormal, leaky blood vessels grow under the retina. They bleed and leak fluid, causing scarring and faster, more significant central vision loss.
What are the symptoms people notice?
Main thing is declining central vision. Blurriness, straight lines looking wavy or distorted, metamorphopsia, difficulty reading fine print, needing brighter light, can be more sudden with wet AMD.
Can it be treated?
There's no cure for dry AMD currently. Management focuses on maximizing the vision. They still have low vision aids like magnifiers, good lighting, certain vitamins. ARV's formula might slow progression in some people.
And for wet AMD?
There are treatments. Anti-VEGF injections directly into the eye are common now. These drugs help stop those abnormal blood vessels from growing and leaking.
Injections in the eye. Sounds daunting.
It does, but it's very effective for many people in stabilizing or even improving vision. Laser treatments are sometimes used too. Regular eye exams and using low vision resources are key.
Okay. Ocular melanoma, cancer of the eye.
Yes, the most common primary malignant eye tumor in adults. Usually starts in the uveal tract choroid, ciliary body, or iris, from the pigment cells.
Does it spread easily?
It can because the uvea is rich in blood vessels, often found during a routine exam before symptoms appear.
What symptoms might occur?
Blurred vision if it affects the macula, maybe increased IOP if it blocks drainage, sometimes a change in iris color or shape. Ultrasound helps determine size and location.
And treatment?
Depends on size and location. Options include radiation, like a radioactive plaque sewn temporarily to the eye wall, laser therapy, or sometimes removal of the eye enucleation.
The enucleation, we touched on that. There's also exoneration. What's the difference?
Enucleation is just removing the eyeball. Exoneration is much more extensive, removing the eyeball, plus surrounding tissues, maybe eyelids, even some bone, usually only for very invasive tumors.
And after enucleation, they get a prosthetic eye.
Yes, usually an implant is placed in the socket first for volume and movement. Then a custom-painted prosthesis is fitted later, maybe a month or so after surgery.
Emotional support must be huge.
Absolutely crucial, both before and after. Post-op, monitor vitals, check the pressure dressing, report any bright red drainage immediately.
Okay. Hyphema blood in the front chamber.
Yes, blood in the anterior chamber, usually from trauma. Often resolves on its own in 5-7 days if managed correctly.
How is it managed?
Rest, often semi-Fowler's position to let the blood settle down. Avoid sudden eye movements, maybe cycloplegic drops to relax the iris. Eye shield for protection. Restrict reading, TV initially.
Contusions, the classic black eye.
Right, bleeding into the soft tissues around the eye from blunt trauma. Bruising, swelling, pain, light sensitivity, maybe double vision.
What's the first thing to do?
Ice. Apply ice immediately to reduce swelling and pain. And always needs a proper eye exam to rule out internal damage.
Okay. Foreign bodies, dust, grit.
Common stuff. If it's superficial, try to locate it, have them look up, gently pull down lower lid. Try to remove with a wet cotton swab. Or look down, if with the upper lid over an applicator, try swabbing if seen there.
But what if it's a penetrating object? Something stuck in the eye?
Huge emergency. Rule number 1, never remove it yourself.
Why not?
It could be holding structures together. Removing it could cause catastrophic damage.
So what do you do?
Protect the eye immediately. Cover it with a rigid shield like a paper cup taped in place. No pressure. Keep the person upright if possible. No bending over. Get them to an ophthalmologist stat.
And diagnostics, X-ray, CT.
Yes, to see the object, check for fractures. But again, NO, MRI if it might be metal. Surgery is almost always needed.
Chemical burns, another big emergency.
Absolutely. Priority number 1, irrigation. Immediately and continuously.
With what?
Sterile saline or eye wash solution ideally. At least 10-15 minutes, maybe longer. Use lots of fluid, like a liter. If outside a hospital, use tap water initially, anything clean. Flush, flush, flush.
And what?
Check the pH of the eye surface with litmus paper. Keep irrigating until it's near neutral, around 7.0. Then assess vision. Document everything. Try to identify the chemical. Lactated Ringer solution is sometimes preferred for irrigation as its pH is closer to tears.
Got it. Last eye topic, tissue donation, cornea donation, right?
Mainly corneal tissue, yes. Comes from donors shortly after death. Handled by eye banks.
Anything specific nurses do for potential donors?
Discuss the options sensitively with family, following protocols.
Oh.
If donation proceeds, postmortem care includes raising the head of the bed 30 degrees, antibiotic eye drops, closing the eyes, maybe a small ice pack.
And for the recipient getting the transplant?
They might get short notice. Pre-op, ease anxiety, check their eye for any infection, report redness, drainage, antibiotic drops,
Post-op care?
pressure patch, and shield, usually for a day. Don't remove unless ordered. Monitor vitals, the dressing.
Yeah.
Elevate head, position on non-op side. Watch for bleeding, infection, and rejection.
Rejection signs.
Remember RSVP, redness, sensitivity to light, decreased vision, pain, any of those. Report immediately. Rejection can happen anytime. Treated with steroid drops. They'll wear a shield at night for about a month.
Yeah.
No rubbing.
Wow, that was an incredibly thorough tour of the eye. Anatomy, tests, disorders, fantastic.
It's a complex organ.
Okay, let's transition now to our other vital sensory organ for today, the ear. Anatomy and physiology first.
Right. The ear, 2 main jobs.
Mm.
Hearing, obviously, and also balance, our sense of equilibrium.
And it has 3 parts too, external, middle, inner.
Exactly. External ear is the part we see, the pinna or auricle, plus the ear canal leading inwards.
Okay.
It's embedded in the temporal bone on the side of the head. The canal runs from the outside into the tympanic membrane, the eardrum. Includes the mastoid process bone behind the ear, too.
Then the middle ear, behind the eardrum,
Yep, an air-filled space. Contains those 3 tiny bones, the ossicles,
the hammer, anvil, and stirrup.
malleus, innicus, and states, yes.
Mm.
Their job is to conduct sound vibrations from the eardrum across the middle ear to the inner ear.
Do they do anything else?
They amplify the sound a bit.
Mm.
And there are tiny muscles that contract to protect the inner ear from really loud sounds. Also, the eustachian tube connects the middle ear to the back of the throat.
What's that for?
Equalizing pressure. Keeps the air pressure in the middle ear the same as outside ear pressure. Essential for the eardrum to vibrate properly. Think about your ears popping on a plane.
Right. Okay, then the inner ear. Sounds complex.
It is. It's a fluid-filled labyrinth, deep inside the temporal bone. Houses the organs for both hearing and balance.
What are the main parts?
You have the semicircular canals, 3 loops filled with fluid and hair cells, connected to the vestibular nerve. They sense head movement for balance.
Okay.
Then there's the cochlea, looks like a snail shell. That's the organ of hearing.
Inside the cochlea.
It's the organ of Corti. Contains specialized hair cells that are the actual receptors for sound. They turn vibrations into nerve signals.
And the nerve.
That's the 8th cranial nerve, the vestibulocochlear nerve. It has 2 branches, the cochlear branch for hearing signals, and the vestibular branch carrying balance information from the semicircular canals.
So putting it all together, how does hearing work?
Sound waves enter the external canal, vibrate the eardrum. Ossicles in the middle ear transmit and amplify these vibrations to the oval window, an opening to the inner ear.
Okay.
This creates pressure waves in the cochlear fluid. These waves move the hair cells in the organ of Corti.
Bending the hairs.
Bending the hairs triggers nerve impulses. Cochlear nerve sends these impulses to the brain, and we perceive sound.
And balance.
Head movements shift the fluid in the semicircular canals. This bends hair cells there, sending signals via the vestibular nerve about head position and motion.
Amazing systems. Again, assessment details are elsewhere, so let's jump to diagnostic tests for the ear.
Okay. Tomography is one, like CT, uses X-rays for detailed images, but focuses on slices. Good for looking at the mastoid bone, middle and inner ear structures.
Useful for tumors?
Can be, yeah, like acoustic neuromas. Need to remove jewelry, use eye shields, stay still. Contrast might be used, so check allergies.
Audiometry, that's the standard hearing test, right?
Pretty much. Measures hearing acuity. Includes pure tone testing, finding the softest sounds you can hear at different pitches, frequencies.
And the results go in an audiogram.
Yep, that graph showing hearing levels for each ear. Also, usually includes speech audiometry testing, how well you understand spoken words. Helps determine the type and degree of hearing loss.
Okay. Electronostegmography, ENG. Sounds complicated. What's it testing?
It evaluates the balance system, the vestibular part of the inner ear, by measuring nystagmus.
Nystagmus, the involuntary eye movements.
Exactly. ENG records those eye movements using electrodes placed around the eyes. They look for abnormal patterns, either spontaneous or induced.
How do they induce it?
By having you follow lights, changing head positions, and often by irrigating the ear canals with warm and cool water. That temperature change stimulates the inner ear.
Does that feel weird?
Can definitely cause temporary dizziness, maybe nausea. Important to warn the client. Need to be NPO before, avoid caffeine, maybe stop at certain meds. It's a longer test. Assist with walking afterwards.
At MRI again. Useful for the ear too.
Yes, great for soft tissues. Yeah. Can visualize the inner ear structures, the auditory nerve, check for tumors like acoustic neuromas, inflammation, very detailed images.
Okay, so those are some key tests. Now for ear disorders. Risk factors similar to the eye. Aging, infections.
Pretty similar list. Aging, infections, certain medications, ototoxic drugs are a big one, trauma, tumors.
Let's talk about hearing loss types again. Conductive first.
Conductive loss means sound is blocked somewhere in the outer or middle ear. Doesn't reach the inner ear properly.
Like earwax buildup?
Exactly. Or fluid in the middle ear, perforated eardrum, problems with the ossicles, maybe a tumor, often treatable, might be temporary.
And sensorineural hearing loss.
That's damage to the inner ear, the cochlea, or the auditory nerve itself. Sound gets through, but it's not processed correctly or transmitted to the brain properly.
Causes. Loud noise.
Loud noise exposure is a major one. Also aging, presbycusis, ototoxic drugs, head trauma, infections, genetic factors, Ménière's disease. This type is usually permanent, often affects clarity more than just volume.
Any other types?
Mixed loss is just a combination of both conductive and sensorineural. Central hearing loss is different. It's a problem in the brain's processing centers. The ear might work fine, but the brain can't interpret the sound.
The book has boxes on signs of hearing loss and communication tips. Can you summarize?
Signs include asking people to repeat often, trouble in noise, turning up TV loud, maybe withdrawing socially.
And communication strategies.
Get their attention first. Face them. Good lighting. Speak clearly. Moderate pace. Don't shout. Reduce background noise. Rephrase if they don't understand. Be patient. Use gestures or writing if needed.
What about interventions like cochlear implants? Who gets those?
Usually for severe to profound sensorineural loss in both ears when hearing aids aren't helping much, it's a surgically implanted device.
How does it work? Bypasses the damaged part.
Essentially, yes. An external processor converts sound to electrical signals. These are sent to an internal implant with electrodes placed inside the cochlea, directly stimulating the auditory nerve fibers.
Yeah.
The brain interprets these signals as sound, requires surgery and significant rehab.
And regular hearing aids.
They just amplify sound. Best for conductive loss or mild-moderate sensorineural loss. They make everything louder, including background noise, which can be a challenge. Don't restore clarity if the nerve damage is bad. Lots of styles need proper fitting. Education on care, batteries, adjustment is key.
Presbycusis, the age-related hearing loss.
Right. Gradual sensorineural loss usually starts with high frequencies, very common in older adults. Caused by wear and tear in the cochlea, maybe vascular changes. People often say they can hear but can't understand, like mumbling, usually permanent. Hearing aids are the main help. And remind people, no cotton swabs in the ears.
Good reminder. External otitis swimmer's ear. What's that?
Inflammation or infection of the external ear canal skin, often bacterial or fungal. Moisture trapped after swimming is a common trigger.
Symptoms. Pain.
Yes, often significant pain, especially when touching the outer ear. Itching, feeling blocked, redness, swelling, maybe drainage, can cause temporary conductive hearing loss from the swelling. Keep the ear dry. Healthcare provider cleans the canal. Antibiotic, antifungal ear drops are the mainstay. Pain relief, maybe oral meds if severe. Prevent by keeping ears dry, avoiding sticking things in.
Otitis media, middle ear infection. Common in kids. Myringotomy is mentioned.
Right. Otitis media is infection inflammation behind the eardrum, often with fluid buildup. Myringotomy is making a small cut in the eardrum to drain that fluid and relieve pressure. Sometimes tiny tubes, PE tubes, are inserted to keep it draining and ventilated. Post-op care involves keeping ear dry, watching for drainage or infection.
What about chronic otitis media?
That's persistent or recurring middle ear inflammation infection. Can lead to eardrum perforation, ongoing drainage, hearing loss, needs regular cleaning, maybe antibiotic drops, often requires surgery,
Surgery like?
laryngoplasty to repair the eardrum, tympanoplasty to rebuild the eardrum and ossicoscles. If infection spreads to the mastoid bone, a mastoidectomy might be needed to remove infected bone. Post-op involves keeping ear dry, antibiotics, watching hearing.
Mastoiditis infection of that bone behind the ear.
Yeah.
Sounds serious.
It is. Usually a complication of untreated otitis media. Pain behind the ear, often worse than the ear infection itself, swelling, redness, fever, maybe ear drainage. Can lead to major complications like meningitis, facial nerve damage, needs IV antibiotics, often mastoidectomy surgery. Post-op care focuses on monitoring for those complications, wound care, managing dizziness.
Otosclerosis, abnormal bone growth in the middle ear.
Yes, specifically around the stapes bone, causing it to get stuck or fixed. Prevents vibration, leads to conductive hearing loss, often hereditary, bilateral, starts in young adulthood.
Symptoms. Hearing loss.
Slow, progressive conductive hearing loss. Tinnitus, ringing, roaring. Sometimes vertigo. Hearing aids can help. Surgical option is often stapedectomy.
Stapedectomy. Replacing the stapes.
Removing the fixed stapes and replacing it with a tiny prosthesis that can vibrate. Can restore hearing significantly, but has risks: total hearing loss, vertigo, nerve damage. Post-op involves avoiding pressure changes, sneezing airfully, keeping ear dry, managing dizziness. Hearing might be worse initially due to packing.
Labyrinthitis, inner ear infection.
Inflammation of the inner ear labyrinth, often viral, or follows a middle ear infection. Main symptoms are sudden, severe vertigo, nausea, vomiting. Hearing loss in that ear can be permanent. Tinnitus, nystagmus, needs rest, antivertigo meds, antibiotics if bacterial, monitor for meningitis signs. Balance issues might persist.
Ménière's syndrome, known for vertigo attacks.
Yes, debilitating vertigo attacks are classic. It's an inner ear disorder, believed to be caused by excess fluid, endolymph buildup, endolymphatic hydrops.
Triad of symptoms.
Vertigo, episodes lasting minutes to hours. Fluctuating low-frequency hearing loss, gets worse over time. And tinnitus, often a low roar or hum, plus a feeling of ear fullness or pressure. Very unpredictable. Safety during attacks is key.
How is it managed?
Try to reduce frequency, severity. Low sodium diet, fluid restriction, maybe diuretics. Avoid caffeine, alcohol, stress triggers. Medications for acute attacks, anti-vertigo, anti-nausea. Vestibular rehab can help balance. If severe and meds fail, surgical options exist.
Surgery.
Endolymphatic sac surgery to help drainage, cutting the vestibular nerve, or even labyrinthectomy. Destroys inner ear function on that side. Cures vertigo, but causes deafness in that ear. Post-op care involves managing dizziness, safety, speaking to the unaffected ear.
Acoustic neuroma, a tumor.
Benign tumor on the vestibulocochlear nerve, CN8. Grows slowly, usually on the vestibular branch. causes progressive, one-sided hearing loss, tinnitus, balance problems, can eventually affect facial nerve too.
Treatment.
Usually surgical removal via craniotomy, trying to preserve hearing and facial nerve function. Radiation is another option. Post-op care is like other brain surgeries.
Ear trauma can happen lots of ways.
Blows to the head, pressure changes, barotrauma, objects in ear, can rupture eardrum, damage ossicles. Hearing loss depends on the damage. Small ruptures often heal. Bigger ones or ossicle damage might need surgery, tympanoplasty.
Okay, last topic. Cerumen impaction and foreign bodies. Ear wax buildup.
Very common cause of blocked ears and conductive hearing loss. Can remove by irrigation with warm water saline if the eardrum is intact and no infection. Softening drops beforehand help. Gentle irrigation technique is important. Ear candles and dangerous. Don't use.
Foreign bodies. Kids stick things in ears.
Happens often. Vegetable matter needs care, can swell with water. Insects. Kill first. Mineral oil, alcohol may be light, then remove. Other objects. Skilled removal with forceps loop. Avoid pushing deeper.
All right, that covers a huge amount on the ear. Let's circle back to that critical thinking question from the start. Client with sudden eye pain, something hit it, entrance wound noted. What should the nurse do?
Emergency. As the chapter says, the priority is get the client to a room immediately, notify the RN and the healthcare provider. Penetrating eye injury needs immediate ophthalmology consult.
And absolutely do not remove the object.
Absolutely not. Could cause way more damage. Protect the eye with a shield, like a cup, no pressure. Keep patient calm and still, if possible, head elevated. Prepare for diagnostics like CT, NO, MRI if metal suspected, and likely surgery.
Perfect. The chapter ends with practice questions. Really reinforces everything.
Definitely. Questions cover post-op cataract care, no bending. Glaucoma meds, lifelong. Retinal detachment signs, curtain, floaters. Hyphema, semifoulers. Contusion, ice. Chemical burn, irrigate. Enucleation, report bright red drainage.
Also, eardrop technique, pin it up and back for adults. Talking to hearing impaired, normal tone. Insect in ear, mineral oil. Presbycusis, age-related sensorineural. Ménière's, avoid sudden head moves, low sodium. Glaucoma risk factors like cardiovascular disease. Really tests the key takeaways.
Reviewing those questions and rationales is a fantastic way to solidify the learning.
Well, that truly wraps up our incredibly detailed deep dive into the eye and the ear based on that comprehensive Saunders chapter.
We've covered a massive amount: anatomy, physiology, diagnostics, all those disorders, key nursing actions.
It really highlights how intricate these sensory systems are, doesn't it? And how vital understanding them is for healthcare pros.
You should definitely have a much clearer picture now, a solid foundation on these topics.
Hopefully you had some aha moments listening along. Maybe think about how this info connects to your own interests or work.
And maybe a final thought to leave you with. Considering the sheer complexity of our eyes and ears and how science keeps advancing, what breakthroughs do you think might be next in how we understand and treat sensory disorders? Something to ponder.
That brings us to the end of our comprehensive overview of this chapter on the eye and the ear.
Thanks for joining us for the deep dive.